Yes, it connected. So, good morning. Today we start the series of 3 lectures. We will start today with the metabolism of ions and water. So that's the opening lecture to this topic. Then the next lecture will be related to biochemistry of kidneys, since you know that the kidneys, they handle with the water and ions and waste products in our body. And then the Cert, that will be the next week, we will do the amino acid. The acid-base balance. So today we will to some extent repeat the information that you received last year, since there we spoke about the chemical composition of blood plasma. So we will mention something, but we will try also to look at it from the global perspective. That means that it's not only important to know how or what is the concentration of some compound in blood plasma, but also what is the total amount of the compound of the ions in our body. Yes? So we will, for example, look at sodium, potassium, and other, and also not only the blood glucose level, but also the amount in the whole body, where they are stored, etc. So first is that we in our body have something what we call internal environment. And basically this means the composition of the fluid that surrounds our cells. And as you know from other organ systems, our body tries to keep some balance, some homeostasis inside. And if we speak about the water and ions and the protons, we can name 4 components of this internal environment. That means 4 components what our body tries to keep stable. So first thing, what our body tries to keep constant is the volume. Yes? This we can call isovolumia. That means to keep the stable volume of the water in our body. Second is the constant tonicity, that means constant osmolarity. It means isoosmolarity, and that means that our body tries to keep the stable osmolarity, and that we have hormones to do this. Third part is the constant ion composition. That means you have hormones to keep, for example, standard amount of sodium, standard amount of potassium, calcium, etc., for the normal homeostasis. This we call isoionia. And the last, since this will be the topic for today, and then next week we will speak about the maintaining of constant pH, that we can call isohydria. That means the normal concentration of hydrogen protons, normal concentration of acids and bases. So today we will try to look at the constant volume, constant osmolarity, and the constant ion composition, and how this is done. So first, if we return to the previous year, when we start speaking about plasma, we defined a term whole body water. So whole body water means what portion of your body is made of water. As you know, this makes in adults majority, so more than 50%. The ratio is typically 55 to 60% for adult male individual. The more fat you have, the lower amount of whole body water you have, since fat means hydrophobic compounds, and these compounds hate water. That means more fat you have, the lower amount of whole body water you have. So if you have obese male individual, you have not this value, but you have lower. If you have morbid obesity, you can be also, for example, 40. And normally, if you have the physiological male and female, as you know, typically females have physiologically more fat inside the body, and therefore there is this sex difference that adult females should have slightly lower amount of water, but it has no negative consequences. Yes? So for women, you can here be around 50–55%. Yes? But if you have obese male, then they fall much below, and therefore it's better to say that the amount of body fat modifies it than the sex, yes? As you know, 30% of population right now suffers from obesity or are overweight. So this is much bigger factor that modifies it. You know that this amount is not constant during your life, and basically if you are young, then the amount of whole body water is higher. So if you have a newborn, the amount is up 70%. Yes, it can be 70, 75. If you come to premature newborns, there it's even more significant. And the other part of the spectrum, or the opposite part of the spectrum, that means the old person, they have typically lower amount of whole body water. And both the high and the low could have a risk for the patient, and you will learn that if, for example, diarrhea is affecting the small children or the old person, the results, the consequences on the cardiovascular system will be much more severe, yes, than in the adult person. Physiologically, there is the fluctuation of whole body water in the pregnancy. Do you know why? One more time.
There's this amniotic liquid.
That's true. So that's first, the amniotic fluid. What else?
We count the baby into this whole body water.
Of course, the baby is inside.
The baby is very much water.
That's true. You have one sack of water inside your body. That's true. There's the amniotic fluid plus the baby inside. And what else?
Maybe there is more blood.
That's true. But if it's full blood, then it's not so strict, but there is especially more plasma. There is plus 25% of blood, but plus 50% of blood plasma. So basically there is higher accumulation of water in your body due to what? Due to hormones produced by placenta, yes? So estrogens quite heavily accumulate the ions, yes? And plus ions, you have water, yes? So you will learn, we have it at one of the last lecture in summer semester, the biochemistry of pregnancy, newborns and lactation, where we will speak about the accumulation of water and the role of hormones on it. Right now you know that it happens, that typically the female sex hormones stand behind it, and it's the physiological, after the birth in some time, you release the water and you excrete it by the urination.
So less water excretion.
What?
So it's like less water being lost from the female. That's like how it's like.
Yes, in the pregnancy you accumulate the water. Then if everything was physiological, so physiological blood losses, etc., then you excrete that water, yes? You know that the small fluctuations of the water are typically during the period, yes? In the different phases, when estrogens are high or progesterone is high, also the ladies accumulate the water in the body. And pregnancy is from this longer perspective, so it durates months and not days. You know that this fluid can be subdivided to 3 spaces, or to liquids in 3 spaces. The first is the intracellular space, that means inside the cells. Then you have extracellular space, that means outside the cells, and this can be subdivided to 2 other spaces. That's the fluid that's inside the vessels. That means that's inside the lymph or blood vessels, that we call intravasal fluid. And then the last compartment is the interstitial fluid, that means the space inside the tissues. You know that, for example, in liver or skeletal muscle, the cells are surrounded by some liquid. The proportions that you have here are true for the adult person. So in adulthood, you have 2/3 of whole body water in intracellular fluid, 1/3 of the water in the extracellular fluid, and out of this 1/3 you have around 25% in intravasal fluid and around 70–75% in the interstitial fluid. So that's the balance. If you take a newborn, then it's switched, so they have the predominance of the extracellular fluid that makes 2/3, and the intracellular fluid makes only 1/3 of the fluid. This is the other risk factor, since to lose the fluid from extracellular fluid is simpler. Yes, so that means that the newborns and small children, they can be dehydrated quicker, since they can lose the extracellular fluid quicker, and inside it they have the majority of the fluid. Except of these two spaces, you have the other thing that we call the Cert space. The fluid in the Cert space means the fluid in some preformed cavities. Yes, we can say. That's, for example, the pleural, pericardial, and peritoneal cavity. You know that physiologically inside these cavities you have quite low presence of the fluid. Yes, some 1, 2, 5, 10, 15 milliliters. It depends on the size of the cavity. Of course, you have possibility to highly increase the amount of fluid here. So, for example, you know that if you have accumulation of fluid in peritoneal cavity, we call this ascites. It's typical for the people with liver problems, and you can accumulate there several liters. The same in the pleural cavity, you can have accumulation of the fluid. You can see it, for example, on the chest X-ray. There you will see the white color, and that means that there is some liquid. Yes, it can be water, or it can come from some inflammation, and of course there can be, for example, 1–2 liters inside this cavity. Yes. The pericardial cavity is quite small, so here you cannot accumulate a lot of liquids, since it will constrict the heart function. Yes, and it can kill you quite quickly. Second is the fluid that you can find inside the joints, so that we call synovial fluid. Typically, you know, also quite small volume, but those of you who have the experience with the accumulation of fluid there, you know that the orthopedics then can remove quite significant volume. Yes, it's not liters, but it can be some milliliters, tens milliliters, etc. So that's other possibility where you can accumulate. Then you have the cerebrospinal fluid. Cerebrospinal fluid is inside the subarachnoidal space, and then also in the chambers, in the brain, and in the canal inside the spine. And the principle here is that it makes around 150 milliliters that you 3 times per day recycle, and it helps the brain normal metabolism. It protects the brain, since it's not with the direct contact with the skull, but there is some fluid where it can flow on. So it's also the protective function for the normal brain, brain function and structure. And the last, what you have here is the fluid secreted to, for example, GI tract or to urinary system. You know that per day in GI tract you release quite significant values. How much? 10. Yes, 7, 10, it depends. But it's in liters. And if you have severe diarrhea, then you can lose this. Yes? So it can be quite big amount. The same if you look at the kidneys, at the primary urine. Per day you produce 180 liters of the primitive urine. And from this you must around 99.5% of water recycle back to your body, so reabsorb it, and only small amount of that urine is what we call a definitive urine, yes? And next lecture we will speak what happens if you have, for example, some hormonal problem and you will have polyuria, and in some of these hormonal defects you can lose, for example, 15-20 liters of urine. And this also brings very severe consequences to your whole body water balance. So these fluids of third space, they have sometimes intensive, sometimes extensive metabolism, but all of them are necessary for the proper function, and they basically communicate with the extracellular fluid, since some of them are produced by the ultrafiltration of the blood plasma. Yes, the basic example what you have is the primitive urine produced in the kidneys, in the nephron. Any question to this, to the body fluids, to the volume? So what do we speak about? So what you should know is the volume. So if you have 70 kilograms, this means around 40-45%, liters. Out of these, 2/3, 1/3, and here are the volumes. Yes? So this is the first component, that's the volume. Second component that we should speak about is the osmolarity. Here you have written plasma osmolarity. Plasma osmolarity is the thing what you will measure. Yes, that means you can collect the blood and you can measure what is the amount of compounds that are dissolved in the blood plasma, and if you make the sum, you have the osmolarity. So the normal plasma osmolarity is around 280 to 295 milliosmoles, or you can write it in millimoles. Yes, it should be milliosmoles, but very often you read millimoles. Of course, this is only one osmolarity that you can measure, since osmolarity you can basically measure for other fluids also. So you can measure osmolarity of the intracellular fluid, you can measure osmolarity of, for example, the interstitial fluid, but basically for the doctor perspective, the osmolarity of blood plasma is the thing what you will see, since you can basically collect only the blood plasma or maybe the lymph. And then, of course, that we will speak next lecture about, it will be the urine osmolarity. If you do not remember this value, you can still try to estimate it, or you can try to calculate it. And to do the estimation, you can basically by this simple formula, that is the utilization of the fact that the plasma osmolarity is typically determined by low molecular weight compounds. That means by ions, nutrients, and metabolites. So if you take from each of this group the main representative, you can have the estimation of the osmolarity, or the calculation of the osmolarity. But of course, inside the formula is not everything, so it will be lower than the actual one. And this calculated osmolarity's formula is 2 times sodium, 1 time glucose, and 1 time urea, so metabolite, nutrient, and ion. Question, why here do we have 2 times concentration of sodium? And what ions, for example?
Chloride and bicarbonate.
I think that's like in K plus.
So, chlorides, bicarbonate, sulfate, phosphate, all organic components. That is, for example, lactate. Inside you can have citrate, other amino acids, and also inside you have the plasma proteins. Since you know that plasma proteins inside the body pH, the plasma pH are typically in form of anions. So that means that here, with 2 times sodium, since you know that at the site of cations, the situation in plasma is highly non-democratic, that there is very big authority of sodium with 140, and the potassium is around 4.5, yes? And that means that 2 times sodium is enough for this estimation. If you come to that formula, you calculate it, you have the calculated osmolarity, and then from the lab you gain the measured osmolarity. Yes, that means the actual that the patient has. And if you have both these values, you can calculate very simple parameter that's called osmotic gap. The osmotic gap is the physiological thing, since the calculated osmolarity must miss something. For example, there is no potassium, there is no calcium, there is no magnesium, and other things. And that means that physiological range is around 4 to 12 millimoles. Yes, that means it must miss something, the calculated osmolarity. If you are in this range, you know that there is in the blood nothing what heavily modifies the osmolarity. On the other hand, if you find that the osmotic gap is high, higher than the normal range, you know that in the blood is something what modifies the osmolarity and is not inside this formula. What it can be, it can be, for example, compounds that lead to the poisoning. The most common compound that you would name is? Alcohol. That's true. So how big is the impact of ethanol on osmolarity? That's true, in one word, big. Yes. So it's 1 promille is around 20 millimoles or milliosmoles. 1 promille. That means the concentration, but not percent. Yeah, I think in English it's also promille, this thing. Yes? Yes, around, I think 20 it's precisely, yes. 20 milliosmol. But in general it's quite big. So if you have 2 promille, you have quite big osmotic modification. The same can be for methanol. The same can be, for example, for ethylene glycol. Yes? And other compounds that modifies the osmolarity and are not inside this formula. So the osmotic gap is a very simple parameter that you will heard by the doctors about that helps them to do some first idea what the state could be about. Yes, the same will be, for example, an ion gap that we will speak next week about that will help us to assess the problems in acid-base balance. Osmotic gaps helps you in some defects or some pathological states inside the internal environment in the osmolarity and volume settings. So if you are above the range, and you, for example, feel the ethanol smell from the patient, then you can say, good, the osmotic gap is high, there is this, so the alcohol should be the reason. If you see the alcohol, or if you feel the alcohol smell, but the osmotic gap is absolutely normal, then maybe what we can say there was only 1 shot, and then there were some pills, for example, coupled with this. Yes. Of course, that then you will send the blood to the toxicology, etc. But the osmotic gap is quite simple parameter, the same as an ion gap next week. How do we regulate the osmolarity? You know that in our body we have several systems that regulate the water, ion, and osmotic balance. And what is quite important for you is to distinguish what system does what. If we look at the osmolarity, it means that you must modify the ions or other compounds that are dissolved and or the water. If you modify both, then the result on the osmolarity is nothing. So if you, for example, look at the basic principle of Renin-Angiotensin-Aldosterone system, so the aldosterone does the absorption of sodium, and this is coupled with the water coming back to the organism. That means that from the result on osmolarity, you have almost nothing. Since ions plus water, that means osmolarity stable. And therefore, renin-angiotensin-aldosterone system is not the main system to keep the osmolarity. It will be important to maintain the volume, to maintain the sodium balance, but not the osmolarity. And the system that does the osmolarity regulation is the antidiuretic hormone or vasopressin. Yes, that's the synonyms. What does the antidiuretic hormone? We will in detail describe next lecture. But today, I can tell to you that you have some tubules in the kidneys, and this some of them are impermeable for water, for the free water. So this is the collecting duct, collecting tubule, and the cells typically, without no presence of antidiuretic hormone, are impermeable for water. That means that in their apical membranes you cannot find aquaporins. What happened if there is no antidiuretic hormone? You will produce high quantity of hypotonic fluid. That means fluid with low osmolarity. If you secrete the antidiuretic hormone from your pituitary gland, from the posterior lobe of the pituitary gland, then this antidiuretic hormone binds to the receptors, does some second messenger signaling, and at the end, you here incorporate the aquaporine type 2 inside the apical membrane of the cells inside the collecting duct. What is the result? The free water will move back to your body, and the ions stay inside. In that situation, you will produce low quantity of hyperosmotic urine. And the biggest osmolarity could be, for example, 1,200, 1,400. If you compare this with your own body osmolarity, that's in plasma 280 to 300, you excrete the ions and you keep the free water inside. That means the antidiuretic hormone decreases the diuresis, it increases the volume in your body, plus it decreases the osmolarity. So it modifies the movement of free water, and by this it keeps the volume and it modifies the osmolarity. And especially the osmolarity has quite big impact on its secretion, and the modifications of antidiuretic hormone secretion are, as you see, modified even by very small changes of osmolarity. So the osmolarity is really strictly regulated, and what you regulate is the movement of free water. And renin-angiotensin-aldosterone that does movement of ions accompanied by water, it's not a hormone to regulate the osmolarity. Do you understand this? This is one quite common question if you have something related to this in the exam. Yes? So, what is the hormone that regulates volume? What is the hormone that regulates osmolarity? And what is the hormone that regulates the sodium, for example? Yes? And you should be able to explain why aldosterone is not the main regulator of osmolarity. Or here it's written only how it's done, that we will speak next lecture.
I have a question about something in the previous slide, which is like the normal variability only plus 1 to 2%.
That means that if it's higher than these fluctuations, you will see the response of antidiuretic hormone. So that means that it's really strictly regulated. Then if you are up few percent differences, you see the response of ADH. So osmolarity is really strictly regulated in your body. It's one parameter that is really extremely strictly regulated. And what do we think that it's quite non-problematic is due to this strict regulation.
And there's another thing, that the increased osmolarity induces thirst, and then the increased osmolarity...
That's the behavioral thing, what you do. So of course, if you are missing something in your body, what you will do? You will try to see for a diet or for a water. So that means that, of course, this is the hormonal action, but then you have the whole behavioral action. That, you know, if you are hungry, we as biochemists, we speak about the degradation of glycogen, about the de novo production of glucose, degradation of other things. But what you will do? That's the behavioral action. That's the same. That's only here written that you should not forget that this is the hormonal action, one thing, but then of course there is the behavioral action. If you are missing salt, for example, if you have Addison disease, that means you have the problems of suprarenal gland, you have the salt craving. Since you lose the sodium, so you have the salt craving. This is your behavioral response. Any question?
Thank you.
Here you have the fact, what I said to you, that the antidiuretic hormone keeps not only osmolarity, but of course it also keeps the volume to some extent. Since it absorbs free water, it increases the volume. And there is this fact comes to quite big importance, since the volume of your blood, of your whole body water, is not the main stimuli for antidiuretic hormone secretion, but if you have some significant problem, it will become a stimuli for it. That means that if you have, for example, patient that has car accident and has the bleeding, some significant amount of blood. So what fluid does this patient lose? That's true, so the plasma, and that means isotonic, hypertonic, or hypotonic fluid. Isotonic fluid. So what should be the response of antidiuretic hormone? Nothing. But it's not true, since the reason is that since antidiuretic hormone is the stress hormone that also has ability to keep the volume, then the stress hormones will be activated as whole, and antidiuretic hormone will try to maintain the normal volume, since without normal volume of the blood, you cannot run the circulation, you cannot feed the tissues and remove the waste products. That means that hypovolemia, low blood pressure, for example, due to trauma or some other reasons, that's also stimuli for antidiuretic hormone secretion. And in this condition, the antidiuretic hormone will still absorb only free water without the ions, and therefore the response on this will be lower osmolarity that is physiological. And this you will find quite frequently in patients in critical state, that they have hyponatremia and hypoosmolarity. And still they have secretion of antidiuretic hormone. And you know the explanation, since right now the antidiuretic hormone wants to keep the volume, to keep the circulation running, and the price is to have low osmolarity. Once the state resolves, then the antidiuretic hormone secretion will be decreased, since the osmolarity is low and it must stop its action. So sometimes that's the major thing, is the osmolarity regulation, but also the volume sometimes can into account. And if you want to work at some intensive care units, you very often will see this as the response of overproduction of antidiuretic hormone due to low volume. Do you understand this?
And low volume is due to blood loss.
Yes, for example, blood loss. Since in the blood loss, I can simply tell to you, I did nothing with the osmolarity, and still something happens. Yes? Very often you have combination, that you have dehydration and something. But even if you have only blood loss, that means isotonic fluid loss, this will be the response.
And like in case like of low volume like as well, like wouldn't the Renin-Angiotensin-Aldosterone system be working?
Yes, for the volume, you will use Renin-Angiotensin-Aldosterone, that we will speak in a few minutes about. Yes, but antidiuretic hormone also. Since it keeps both osmolarity and the volume.
And the aldosterone is also a stress hormone.
That's true. The whole axis, both axes are stress axis. This we mentioned last year, so only for your repetition, you know that in clinical practice we have 3 types of fluids: isotonic, hypotonic, and hypertonic fluids. Here we have some examples of the isotonic fluids, but you will meet them much more. And what is for us important is that hypotonic fluid can cause the influx of water to the cells. It can induce the cell edema, and then the edema of the whole organ. Hypertonic fluid, they typically drain the water out of the cells, and what they typically can do is the irritation of the vessel wall where you put it. Yes, so very often you put the hypertonic fluids to the central venous catheter, if you must give them for longer time. And this is what happens to your brain. So if you have the low osmolarity for a very quick time, then it will cause the brain edema, brain swelling. And as you know, the volume of the skull is constant. And inside the skull, you have 3 things. You have their brain, you have their blood, and you have their the cerebrospinal fluid. And the volume of the skull is constant. So if the brain tissue expands, then you basically must reduce the cerebrospinal fluid and then the blood flow. And that's what we will speak about the next semester, how you can try to prevent this happening. Yes? But today you should know hypotonicity, it means brain swelling. It can reduce the other spaces in the skull or the other components there. And of course, at the very end, the brain tissue can be constricted by the bone. And if you have the combat brain versus bone, you know who will win. Yes? The same problem or different problem, but from similar reason, is if you have quick increase of plasma osmolarity, it can cause the demyelinization, especially at the place of Pons varoli. What precisely it will cause, you will also learn next course, where you will have the knowledge what runs there. Yes, I can tell you that it can be, for example, some motoric dysfunction as the result of this. The result means do not play with osmolarity unless you have to, and if you do it quite slowly. Yes, so very big problem is if you do as the doctor rapid, quick correction of osmolarity. When you think in 2 hours I will achieve a normal osmolarity, so then in 2 hours you have the problem.
But why demyelinization?
For this you must have the brain. The brain part, yes. What precisely happens there, yes. So wait 2 months or 3 months when we will return to this. And this is only the scheme. What happens if you do it quickly? What happens if you do it slowly? Yes, but it's the same what I said. Question to the osmolarity and volume. So now the volume. What we have in our body is that you know that there are very often the parameters connected in some series. Yes. So, for example, what you know from the previous here is that if you have the sodium moving somewhere, since it has positive charge, then the sodium takes together with it chloride or some other anion has the negative charge. They will be typically accompanied by the water. And since one of the compartments that we have defined is the intravasal fluid, then this has the consequences for the cardiovascular system, and basically you increase the volume of plasma, and this will be one of the things that can increase blood pressure. What does it mean? That the movement of sodium in your body is connected with the movement of water. That means with the expansion of the compartment where it is. And if we look at the cardiovascular system, the result will be increase of blood pressure. And if we here make at the beginning one note, that's Renin-Angiotensin-Aldosterone system, then you know that the Renin-Angiotensin-Aldosterone system regulates all three things. It regulates the sodium content, it regulates the water content, that means the volume, and also it will be part of the regulation of blood pressure. And next course, when you will speak about the cardiovascular system, you will speak also about Renin-Angiotensin-Aldosterone system, only you will start from this perspective. But today we have the ions and water, so we should speak about this part. So in blood plasma, the situation is that sodium is the main extracellular cation. Concentration reaches 135, 145 millimoles. Inside the cells, as you know, the concentration is much lower, is more than 10 times lower, so you have there around 4 to 12 millimoles. So gradient around 1 to 10, 1 to 12. And of course, along this gradient, the sodium can move inside the cells when you open the sodium channels, as you know, for example, during the depolarization phase of action potential. These two sentences means what I wrote here. So our body in extracellular fluid maintains the osmolarity predominantly with the sodium and with the anions that accompany the sodium. That means that altogether sodium and chloride makes around 80% of the osmolarity, and that means that they also keep the volume of this fluid. So sodium is the main component that keeps the extracellular fluid osmolarity, both in the interstitial fluid and in the blood plasma. And if we speak about blood plasma, it also stands behind the amount of fluid in the cardiovascular system, and this means the blood pressure. And it will modify, for example, the function of the heart. That means it will modify also the cardiac output. So the question is where we can gain the sodium. Yes, what are the balances in the diet and what are the losses? So basically in the diet, the main source of sodium is of course the salt. Here you have some values. So you know that for vitamins we spoke also about recommended daily intake. We wanted you to know what is the intake, for example, for vitamin C, vitamin B12, etc. So here you see the intake, for example, for the sodium, and also how does it correspond with the salt. Right now I can tell to you that you can even put here -1, since where we have problem right now is that in the diet is more salt than we should have. You know that very often we like salty things that have sugar and fat inside. So right now in regions where we live, and I think that also in the regions where you live, the problem is not lack salt, but a lot of salt. And you cannot see a direct effect, but of course you can see some long-term perspective that high intake of salt is one of the risk factors for developing of the cardiovascular diseases. Yes, the same as the high intake of, for example, not quality fat will be the same. That means if you can reduce salt, let's do it, yes? Of course, it has some limitation, but right now our problem is a lot of salt and a lot of sodium. What our body can do with the regulation of the renin, of the sodium concentration. So here we have basically two systems, the Renin-Angiotensin-Aldosterone system and the opposite system, that's the system of natriuretic peptides. So I think that about aldosterone and renin-angiotensin you have already heard, yes, you know it. So basically two peptide molecules, renin, angiotensin, then angiotensin can be converted to type 2, and then you have aldosterone, the stress hormone. Its function from the perspective of hormone of ion balance is absorb sodium, excrete potassium. And what we will add to this next week is also it can excrete the hydrogen proton. Yes? So basically if you keep some cation inside, you must excrete some other cation. The natriuretic peptides, they are the group of hormones that induce both the natriuresis, that means release of or excretion of sodium, and also the diuresis, that means excretion of water, since these two things are coupled together. So with the natriuretic peptides, you lose sodium, you lose anions, and you lose water from your body. We have two basic representatives, the atrial natriuretic peptide and brain natriuretic peptide. Both of them are produced in heart. The atrial one in atrias, the brain natriuretic peptide is in ventricles. And as you know, this is in quite well correspondence with this. So since heart is the pump that should pump the blood inside the cardiovascular system, also it could have the possibility to regulate the volume in the cardiovascular system. So if we take a basic experiment, if you increase the fluid in extracellular space, that means inside your blood vessels also, you will have higher venous return. That means more blood will come to the right heart. This will lead to expansion of the right heart, and as the result, you will have increased tension in the heart wall. This increased tension is the signal for the secretion of the natriuretic peptides. As the result, you will excrete sodium, you will excrete water. That means you will excrete the volume from the extracellular fluid, and it means that you will return to the beginning. That means lower volume of extracellular fluid, lower venous return, normal tension in right heart wall, and as the result, lower secretion of antidiuretic hormone. So this is the basic mechanism how the heart, through antidiuretic peptides or natriuretic peptides, can regulate the ion and water homeostasis. Do you understand it? That's it.
And like, I just have a question, because like the DNP is the brain, and like you explained, I think, like the heart.
It was discovered in pig's brain.
What again?
It was discovered in pig's brain, if I am correct.
And like.
But we produce it typically in the right in the ventricles, in the heart.
So like both, like they are produced in the heart, one in the
yes.
and one in the ventricles, despite
yes.
one causing.
What is written here is the first information why it's important to make a difference between what do we measure in the blood, what is the concentration in the blood, and what can be the amount in the whole body. So for sodium, you can have the situation when you have normal or almost normal serum concentration, but still you accumulate a sodium inside your body. Since once sodium, there water, but the concentration could be normal or almost normal. For example, if you have the edemas, that means you have the leg swelling or you have the ascites, you have higher amount of sodium in your body, but the concentration in the blood can be normal. And you as a doctor, you must distinguish between these two parameters. So basically from the physical examination, if you look at the patient, if you listen to the patient, you can see that there is the excess of sodium and excess of water, since you will see these edemas. In that moment, you must do the therapy to excrete this excess of sodium. For example, that you give the diuretics, you will try to treat the primary reason for it. And at the same moment, you can see that the blood sodium is almost normal. Yes? Do you understand this? So the accumulation of water in your body is typically done by the accumulation of sodium, but the result of this whole body sodium on the blood concentration could be almost nothing. And even in this, you will give the drugs that leads the body to excrete the water, since there is the total excess of water, total excess of sodium with the normal plasma concentration. So that's what students sometimes ask the doctors, but this patient has the normal sodium, why do you give this drug that will lead to excretion? And the reason is, since we want to reduce the excessive accumulation of the sodium and water in the body, and the plasma concentration we know that will be stable, since you will take it from the depot and you will excrete both sodium and the water. So the result could be nothing or very small. Sometimes, of course, you have to supplement, for example, the other ions, but that's the two different parameters. The same we will see, for example, for calcium, yes, or for potassium. And the last before the break, chlorides. Why the last? Since here you have almost no new information from what we mentioned last year. So plasma and extracellular fluid concentration is around 100, and it's the main anion that accompanies the sodium. Inside the cell, the concentration is lower, and you know that if you open the chloride channels in the cell membrane, the chlorides will move inside the cell, yes, along this gradient. And the function of chlorides, it's the osmolarity. Then next week we will speak about the acid-base balance, since chlorides are derived from strong acid. Then that chlorides form the gastric juice, and you know the principle how the gastric juice is produced. And the last function is that from chlorides you can produce hypochlorous acid that has the antibacterial effect inside your phagocytes, for example, neutrophiles. That's it. Regulation is related to the regulation of sodium, yes? So no specific regulation for its content, its concentration. Question?
I didn't quite get like the previous slide, like the idea from it.
What?
I didn't quite get like what's like the idea behind it.
The idea is that what you typically speak about is that you look at the laboratory result and you see there is concentration of sodium this. But that speaks nothing about what is the whole amount of sodium in your body. For example, if you look, very simple perspective is calcium. Where is the predominance of calcium? in bones. Does it reflect the amount of calcium in the blood? Almost no. That's the same here. So you will look for the values since they will help you with something. But the limitation is that the value what you measure in the blood plasma sometimes corresponds well, sometimes mildly, and sometimes almost no connection with the amount of the iron in the body. So that means that if you see the patient that has big edemas, big ascites, you know that there is the actual accumulation of sodium and water in the body, and the plasma value can be almost normal. And if you give the diuretics, you will of course remove the sodium from the plasma compartment, that's true, but there will be the movement of the sodium and water from those edemas, from those accumulations to the plasma. So you will have the balance in this.
And this is like if we have edema, and the other, the first one,
the first one, that means that you also on the patient can see the actual deficiency of sodium, of the whole body sodium and the whole body water. For example, if you have dehydration. So you see that these patients typically will miss the sodium since by sweating and these they lose the sodium, but at the same moment they can be dehydrated. That means that you can see pathologically high sodium. Yes? But or normal sodium if you have the patient with the bleeding. Yes, if you bleed out, you lose water in the plasma and also the sodium. So if you will then instantly collect the blood, you will see that the concentration is normal. Yes, but then you will see that it will decreases. Yes, since the total amount will be lower. So that means that you should take, when you speak about ions, you should take into account that there are things what you measure in blood, and then the situation in the whole body. And this, that means the situation in the whole body, you typically assess by the clinical examination. So if you see edemas, you know there is sodium, there is water in accumulation in the tissue. I must excrete the sodium, excrete the water from the body, and at the same moment you can see that sodium is normal or almost normal. And still you will force the body to excrete the sodium. That means you do not give drugs to excrete sodium only if there is hypernatremia.
And like in the first one, I might have also like the normal concentration of sodium in the blood, but like I might have an overall increased amount in the body.
Yes, that's it. So if no other questions, then we will take break till 50. So the next ion is potassium. For potassium, we come to the ion that is mainly in intracellular fluid. Here you have the concentration, so around 155, and in the extracellular fluid, the concentration is only around 3.8 till 5.2. From these two numbers, you can see that quite simple thing that can lead to the increase of extracellular calcium is the shift, the movement of this potassium to the extracellular compartment. Yes? And we will in quite big time speak about this, since this is very significant way how you modify the value of extracellular calcium. That means the movement inside the cells or movement outside the cells. And also, this explains to you why the plasma value tells you almost nothing about the actual concentration, or sorry, actual amount in the whole body. Yes? So even small hypokalemia can be the signal for very big depletion in the whole body. And there is some estimation that to modify the plasma value, the whole body change should be around 100 millimoles. That means that in the blood plasma, as you see, you have quite low amount, but if you want to modify it, then the absorption capacity of your cells is extremely big. That means plus 100 milligrams will lead to some modification, since the majority of that calcium will be cached inside the cells. Some numbers about the intake and losses. So per day, you have the intake between 50 and 150 millimoles. It's quite rich in the fruit and vegetable. That means, for example, typically we mention, for example, bananas, we mention apricots, and I think that also in avocado. It's quite big, yes? But when was your last time to eat avocado? Yesterday, that's good. That's good. We typically eat more bananas, yes? But especially fruit, if you say. That means that also this fruits and vegetables must be reduced in some people that have, for example, the kidney problems, since the main way how to lose the potassium is through kidneys. Yes? So if you have limitation of kidney function, you will see that you have also limitations of something in the food. Yes? So for example, you should not eat 1 kilogram of apricots during summer if you have kidney failure. In the stool, you typically lose around 10 to 20 milligrams, but that's if you have the normal stool formation. If you have diarrhea, then here you can have the losses of hundreds of millimoles. And that you will learn that if you have some long-term diarrhea, this can lead to your depletion of potassium stores. Here you have 2 ratios of sodium and potassium in 2 basic body fluids. The first is the serum, and the second is urine. If you see in blood, the ratio is around 32 to 1, if you compare these 2 concentration. If you compare the urinary concentration, here the ratio is 2 to 1 or 3 to 1. From this, you see the fact that really our kidneys heavily absorb the sodium and keep it in the body, and they secrete quite big quantities of potassium. Yes? And the next lecture we will see the precise value of the excretion fraction, and excretion fraction for sodium and potassium will be different, and you really excrete quite big quantities of the potassium in the urine. Therefore, if you have the problem in kidney function, you have significant problem with the potassium balance. The fact that potassium is inside the cell predominantly is done by this NAK ATPase. As you know, we have the potent pump that keeps the normal balance, that sodium is outside and potassium is inside. And this distribution is crucial for the normal function of the excitatory system. That means for your heart function, for your skeletal muscle function, and for your nervous system. This pump needs one very important thing, and the thing is ATP. That means that if you have a tissue that is missing ATP, it will be quite logic that it's not able to keep this physiological distribution, and you will have the excess of extracellular potassium and decrease of the intracellular potassium. That's the typical condition what happens to you in the hypoxic tissues. And if you take the illustrative situation when you have myocardial infarction, that means total occlusion of some coronary artery, then the tissue that's behind this, that should be supplied by it, has hypoxia, and is not able to keep the normal ion balance. And next course, we will speak what consequences it can be, for example, for the generation of the stimuli in the heart. And then, if you do the opening of the obstruction of the thrombus, then, of course, this extracellular potassium will move to your body. If the hypoxia is of smaller region, it has no influence to your whole body metabolism. But if you, for example, have some thrombus in big artery inside the lower limb, and you have the global hypoxia, and you open then that thrombosis, then the amount of potassium that comes to your body can be quite significant, and it can interrupt the normal processes. So the message for you is, if you have some bigger hypoxia in your body, then it can lead to bad function of this pump, and it will modify the distribution of sodium and potassium. Other factor that modifies the distribution of intracellular and extracellular potassium is the pH changes. Here you have it for the acidosis, but only opposite will be for the alkalosis. So what's here the story about is that the acidosis is the state that leads to decrease of body pH. That means to the accumulation of hydrogen protons. And your body typically reacts on this at the first line with the buffers. That means that your chemical compounds, as for example bicarbonate or some proteins, will bind the hydrogen proton to keep the pH stable. And we can say that our cells also can behave as the big buffer, since inside there is a lot of proteins, phosphate, etc. That means that they will accumulate or they will try to catch the excess of hydrogen protons. But as the result, they will release other cation, and that's the potassium. Yes? And what is the result? The potassium from intracellular fluid is shifted to the extracellular fluid, and you see the increase of extracellular potassium as the result of the distribution change. That means that in the patients with low pH, you typically can see that there is also the increase of extracellular potassium. And this is one process that stands behind it. Other process that stands behind it, behind the distribution changes, that's catabolism and anabolism of the proteins. If you have the protein inside a cell, on this protein you have bound some ions at the side chains, and that can be, for example, potassium. If you do the degradation of the protein and you burn it on amino acids to gain energy, to gain glucose, then of course the potassium will be released from the proteins also, and as the result, this potassium will be released to the extracellular fluid. So that means that catabolism is other reason for increase of extracellular calcium, and you decrease the amount inside the intracellular fluid.
Sorry, why?
Since the potassium typically can be bound to that protein, if you lose it, if you burn, if you produce water and carbon dioxide, no other possibility what to be bound to. Then in anabolism, it's opposite. You build up the protein, so you bind the potassium to it, and you can have paradoxical decrease of potassium. So if, yes?
Just because the potassium binds to like the amino acids or the protein?
Yes, to the protein amino acids, yes. And then of course you can speak that what is the catabolism related to energy and the other factors, yes. But if we take it as the simplification, this, then these are the three separate reasons. But if you, for example, to look at the patient with type 1 diabetes, the type 1 diabetes means you have catabolism, you have acidosis due to diabetic ketoacidosis, and you have also partially lack of energy. So these states then can accumulate together. If you have hypoxia, then the hypoxic tissue also has acidosis due to overproduction of lactate when you have no oxygen for complete burning of glucose. So here we say that it's 1, 2nd, 3rd, but very often you have it combined together. Question to this. So this altogether means distribution changes of potassium. That your intracellular potassium can modify the extracellular value only by the fact that you release the potassium from the intracellular stores, and the whole body volume of potassium can be normal. If you want to regulate the potassium content from the whole body perspective, you do it by this system. Yes? So the system Renin-Angiotensin-Aldosterone is the system that accumulates sodium and excretes potassium, and this modifies the potassium value from long-term perspective. So if you, for example, has the patient that has overproduction of aldosterone due to the tumor of the suprarenal gland, of the cortex of the suprarenal gland, and it will overproduce the aldosterone, then you can see the depletion of the potassium instantly to the patient. You can see the increase of potassium, but once it translocates to the cells, you will see back of hypokalemia. That means if you want to supplement the long-term deficiency, it must be also long-term process. Since really for the potassium, the main compartment is inside the cells, and that you must modify. And that durates some time, and the plasma concentration is only small reflection of the state inside your body. So do you understand the difference of distribution and the difference when you modify it from the global perspective by the hormone action? Yes or no?
I have a question about like the enteral glucose.
Mm-hmm.
When the glucose enters the cell, it goes process, right?
Yes. The fact is that what gives you glucose, if you give to somebody infusion of glucose and insulin. You know, it's funny for somebody.
What gives you glucose and insulin?
If I give to you glucose, and not diabetic person, then of course you will cure the state, the insulin. But you will force the body to be in anabolic state. You will help the cells to gain energy, to run the NAK ATPase normally. You do the anabolism, that means you can produce the proteins, and typically catabolism leads to accumulation of acid, so in anabolism you lose the acid. So that means that if you force the body to come into the anabolic state by insulin and glucose, this will lead to the movement of the potassium inside the cell. Since this is the opponent of catabolism, of acidosis, and of lack of energy, since insulin is the anabolic hormone.
What does it have to do with this with the pH? Like how does catabolism?
Since that you should know, lactate, for example. Lactate, or altogether the metabolism acidifies you. Yes, the catabolism acidifies you. You start with triacylglycerol, and at the very end you have ketone bodies. You start with the glucose, and you can have lactate. So that acidifies you. The starvation acidifies you, basically, and insulin is against it. So to give the insulin and glucose is something what you can call the first aid if you have hyperkalemia. If I'm correct, you give calcium to also inhibit the action of hyperkalemia, and then you have glucose plus insulin to force the potassium to go inside the cell. And this is the last picture. if you do not follow the recommendation and you keep potassium increasing or decreasing, this is the result on the ECG. Yes, more how it's done you will learn the next course when we will speak about generation of impulse inside heart, but this is the result and you should have it connected. Problem with potassium can lead to very severe problems in your heart, to the arrhythmias. Magnesium. Magnesium is second most important intracellular cation. Its plasma concentration, as you see, is quite low when compared to the intracellular concentration. Yes, so many facts that were mentioned for potassium are also valid here. Yes, that means the thing what you measure in the blood very often does it informs you about the whole body stores, etc. What are the functions of potassium? Of magnesium? So it's in your bones. As you know, it works as the cofactor and coactivator in enzymes, and also it decreases neuromuscular excitability. You know that magnesium modifies or interacts with the movement of calcium through the membranes, and therefore if you have, for example, cramps, then the magnesium is one way what you can do. Yes. Where you can find the magnesium in the diet, so it's in the milk, then in some vegetable, in whole grains, in legumes, etc. Yes, if you have a normal standard diet, the magnesium is typically not deficient. One risk population where it can be deficient is alcoholism. Yes, if you have the patient with the high consumption of ethanol, very often they do not have the high quality diet, and they could have the significant hypomagnesemia. And if you give them magnesium, it will help, for example, with some the motor problems, or not totally reduce them, but it can be one factor that modifies it. When you will learn about magnesium a lot is in the gynecology obstetrics. Since, do you know the term preeclampsia? So what is it?
It's a state in pregnancy which is signed by, I think, high protein levels, hypertension.
Hypertension.
Hypertension, and it's potentially lethal for the mother as well as the embryo.
Yes, so it's basically the interaction between the fetus and the mother. It's typically with the hypertension, can be protein in urine, and basically, as you know, in pregnancy you do not have many options what to give to the pregnant lady. Yes, it can be quite problematic. Many drugs are forbidden due to the side effects on the fetus. And one thing what you can do without no big risk is, for example, magnesium sulfate. Yes, so if you have, for example, some seizures or some high predisposition to seizure in pregnancy, magnesium sulfate is one thing what you will learn, that it's done to many ladies and it has no side effects on the fetus. Yes, so magnesium routinely you will see there its usage in the gynecology obstetrics, and the details when and how and why in preeclampsia they will explain to you. But that's the thing what you should know. The alcoholic person and then the pregnant women, two populations who sometimes need to have the magnesium supplementation. Calcium. Calcium is the last cation that we will speak today about. So calcium has two important facts. First is that it's very common in your body. Yes, according to the weight, if I am correct, it's the 5th most common element in your body. Yes, so it's very frequent, but it's predominantly in bones and teeth. Yes, and that are the big stores where you have around 99% of the potassium. And then in two compartments that we speak today about. The big portion is in the extracellular fluid, where the concentration is 2.25 till 2.75. And inside the cell, as you know, the concentration is almost negligible. That means it's opposite to the potassium and to the magnesium. Really, inside the cells, you know that the magnesium is, for example, in some compartment as the sarcoplasmic reticulum, but the cytosolic concentration is quite small, and it's 10 to minus 7, 10 to minus 8 moles. So very low concentration. So the biggest portion is in bone, then in the extracellular fluid, in the plasma, quite concentration, but inside the cell, almost nothing. And the gradient between extracellular and intracellular fluid is the highest for calcium, yes? This gradient, that means if you compare this value and this, is the highest for all ions that we routinely meet in the human medicine. Here you have the functions. So I think that all of you know them. So it's important for muscle contraction. It's important for the structure of bone and teeth. It's important for the blood clotting. And then you also know that it's important for the normal function of the excitatory cells. That means, for example, without calcium, we cannot generate the impulse in the heart. Yes? We will say how it's done, but you know it, that without calcium, you cannot secrete the neurotransmitter. Without calcium, you cannot generate the muscle contraction. That means that if you are missing or having a lot of calcium, it will make very severe impacts here. It can be muscle weakness, or on the other hand, very strong contraction. This I mentioned, the gradient, this also, this. The calcium is inside the cells not only good. You know that a lot of calcium will cause can cause the apoptosis process. And that's precisely the balance that our cells must keep. So you, for calcium, must keep the concentration of the calcium inside the cell at the level when it, for example, activates the muscle contraction, or when it activates the secretion of the neurotransmitter, or when it activates the degradation of glycogen. But once you are not able to regulate this, it will be the signal for the cell that it's not able to keep the normal ion balance. And if the cell is not able to do it, then the best way what to do is to kill itself, yes? Since maybe other cells can do it. And as you know, to keep the gradient, you have there the active pumps. So if you have the problem in the function of these pumps, the result will be that you accumulate the calcium inside the cell. It's opposite for potassium, since in hypoxia, the potassium was lacking outside the cell. Here, for calcium, you come inside the cell, since the gradient is opposite. Dobrý den. Jo, ještě máme, myslím, chvilku. Díky. So that's the message, yes, that the potassium is highest in the bones, then in extracellular fluid, then inside the cells. If you break this balance, it can lead to the death of the cell. And the last is this, but this you should tell to me. So what hormones regulate the calcium phosphate? You had it in the first course. So what is it? Thyroid hormone? Tak. Můžeme takom převnout do češtiny, jestli chcete.
Ano.
Ano, ideální. So where do we produce them? Peritoneal hormone, peritoneal gland, calcitonin,
Thyroid.
thyroid gland in the peripheral cells, and calcitriol,
ledviny, játra.
Kůže, játra, ledviny. Jo? Their chemical nature. Calcitonin is
Peptide.
calcitriol,
Vitamin D.
vitamin D derivative. So, and the parent hormone, peptide also. Their function on calcemia, so increase or decrease. Parathyroid hormone,
Increase.
calcitriol,
Increase.
calcitonin,
Decrease.
decrease. And where do they do their action? So parathyroid hormone
On the bones.
and what?
Favorite bones. Key junction.
So you release the calcium from the stores from the bones. And you know 99%. So it's quite big if you wish. And then in the kidneys,
Increase reabsorption.
reabsorption of calcium is increased, excretion of potassium, of phosphate is increased. Calcitriol
Works on the intestines.
was in intestine to absorption of potassium, of calcium, and the same in kidneys. So it wants to keep it inside the body.
And the kidney also stimulates the absorption of phosphate as well.
What? Yes, and there are phosphates as well. And the last, calcitonin,
Stops bone absorption. Stops bone absorption.
yes, it stops bone resorption, therefore keeps it in that store and slightly increase the absorption, the excretion in kidneys. But as you know, calcitonin is, from human perspective, the less important one. Yes, so calcitriol, parathyroid hormone, they are those two crucial. If you are able to say this, then you have one last question in exam fulfilled. Yes, since regulation of calcium phosphate is sometimes the last question that should save the student. Yes, the same as the dissociation curve of hemoglobin. So that's it. That's calcium and its regulation. Any question? Yes, that you can read. Or if you wish, if you will give me 1 minute, I can tell you that we have phosphates, we have it in bones, then we have inorganic compounds, for example, ATP is buffer, and you can have lot of lack of them. But I think that this is simple. If you wish, I can speak about it 2 minutes.
I think we have a Czech exam.
Yes, I know that you have it, therefore I don't want to přetékat do české zkoušky.